Good afternoon, everyone. Today I'm going to present an interesting case of connective tissue disorder with vascular manifestations in it. So we had a 41-year-old female. She was a known case of ADPKD and she presented with multiple episodes of recurrent transient ischemic attacks. This was in June 2021. So this was actually imaging done in an outside hospital. Initially, she had gone to another place. So here, here we are seeing that right ICA is grossly narrowed and it is irregular, and supraglenoid ICA again appears normal in this image. So this is basically right ICA dissection, and as a part of the treatment, there were double stents placed. Telescoping was done and two stents were placed, exact and Exion stents. So this is the pre-embo done, which is showing narrowed ICA, right ICA, irregular, narrowed, completely thinned out right ICA. And after the placement of the stent, we are seeing that the caliber has come back to normal. And just a brief discussion about the stents. So there are basically different types of stents. One is open cell and closed cell. So stent is nothing, these are all metal studs that we are seeing. So if it is, if a cell is covered on all sides by metal studs, that is a closed cell. And if at least one side of the cell is open, then we are calling it an open cell studs. And again, these stents are made in different manners. One is laser cut and braided stents. In the laser cut, we have metal that is being cut by laser beams. And in braided stents, these are like braids that are woven. So wires are woven around it manually. And again, there are covered stents in which metal stents have another layer of fabric over it. And again, one more way of classifying it is balloon expandable and self-expandable stents. So cell design is basically classified into open cell and closed cell. And free cell area is the area within each cell. Like closed cell is each cell is individualized, so area will be small. Whereas open cell, the area of each cell will be very large. Free cell area will be more in open cell. And main important things in stents are the radial stiffness and radial strength. Radial strength of closed cells stents are better. Radial strength is the amount of like the how much it will apply the strength against the wall and how much it will expand the artery. So there are various commonly used carotid stents. Now this is a case of right ICA dissection, mainly C1 segment. So the cervical ICA dissection. So we are so in the neck carotid stents. Commonly used stents are all these: proteage, exact, precise, wall stent, neck stent, and all. And this was not the only finding that she had. She also had intracranial aneurysms. She had saccular aneurysms in bilateral MCA bifurcations. This is the right ICA run, and this here we are seeing are the left ICA run. And both the ones at the left side, we are seeing that there is MCA trifurcation, and here she has a aneurysm, and this has a neck of around 2 mm. And this is the right side. This is also MCA bifurcation. There is an aneurysm which has a wide neck of around 3 mm. So initially, we treated her in 2 sessions. The first session was in October 2021. So these are the initial diagnostic angiogram runs showing us the aneurysm. So here we are seeing that we have navigated the microwire and the microcatheter. We have used a Traxxas microwire and the Phenom microcatheter across the aneurysm distally into the inferior branch of the MCA. And from there, we have deployed the flow diverter. This is the flow diverter from here to here. But on taking a run after that, after 5 minutes, we are seeing that there is stasis within the aneurysm segment. But one more finding that we have noted is that there was some slowing in one of the branch. This is the operculofrontal branch, prefrontal precentral sulcus branch. So this is the flow native image showing us the same, the flow diverter. And here after 10 minutes when we have taken a run, we can see that there is some amount of thrombus formation at the origin of the vessel of this operculofrontal branch. So this is actually an image from October 2021, and this was from the next session, Feb 2023. So here we can see that this branch is still patent, but it is little narrowed in caliber. So actually, when the procedure was, we had given her intraarterial antiplatelets. We have given her tirofiban because there was some amount of clot formation, and we were little scared until the extubation. But once she had extubated, she even started speaking. Also, we were thinking that this was like Broca's area and all. We were a little scared. Otherwise, there was no neurological deficit. Anyway, so talking about flow diverters, basically flow diverters optimally alter the flow between the parent artery and the aneurysm. So they will divert the flow across the artery and not allow any flow into the aneurysm. So there are three properties to a flow diverter, or how it acts. So there is a physical, biological, and physiological action of it. The hemodynamic stage. What I mean by the hemodynamic stage is that it is pushing blood across the artery only and not allowing any blood to go into the aneurysm. Thrombus formation stage, because of stasis within the aneurysm, it will promote the thrombus formation within the aneurysm. And also endothelialization stage. These flow diverters act as a scaffold, and there will be neoendothelialization over these walls. Physical property being physical, physiological, and biological properties being the same, and the flow diversion depends upon the porosity and the pore density of the flow diverters, which are of different. And what are the main complications that we encounter when we are placing a flow diverter? There are some periprocedural complications, mainly are the thromboembolic complications, side branch occlusion, parent vessel injury, incomplete expansion. Here we have noted that there was a side branch occlusion. There was thrombus formation at the origin of the vessel, and post-procedural also there 8% reported of delayed aneurysm rupture and delayed hemorrhage, and there are also perianeurysmal edema. So usually, to avoid the thromboembolic complications, we prime all our patients with at least 1 week of antiplatelets. And this was Feb 2022. This was the second session where the right MCA bifurcation aneurysm was being to be embolized. So here we have here we had planned for an intrasaccular device, which is a contour. So here we can see in this fluoroscopic image that we had taken the microcatheter into the aneurysm, and this is the device, which is like a mesh. Here we are deploying it, and here it is completely covering the neck. And this was the run. After 5 minutes only, we can see that there is significant stasis within the aneurysm. So this is the native image. Here we are seeing on the right MCA side, this is the contour device that we have placed, and this is the flow diverter that was placed previously in October 2021. So contour, these are actually modern devices that are coming up now lately for the treatment of wide-necked aneurysms. It is mainly an intrasaccular device, and as it like flow diverter is an endoluminal device, while contour is an intrasaccular device. So this is placed within the aneurysm, and that is placed within the artery. So flow diverter, to maintain its patency, we keep the patient on a long term of dual antiplatelets. But here, because this is mainly within the aneurysm only, and we are not meddling with the artery, we don't require any dual antiplatelets. That is the advantage. And mainly it is used for wide-necked aneurysms, and all we require is only the widest diameter and the neck of the aneurysm. The size of the neck is very important. It is very important that we cover this contour device along the neck. So contour and web are the main intrasaccular devices that are popular now, and these are basically flow disruptors and not flow diverters. So briefly talking about just aneurysms. Aneurysm is nothing but a persistent dilatation of the blood vessel wall. So there are different types of aneurysm: fusiform dilatation and saccular aneurysms, which are usually at the branch points, and dissecting aneurysm. And pseudoaneurysm, we know that it is not covered by all layers of the wall. So here we have seen dissecting aneurysm in her right ICA in the neck, cervical ICA, and saccular aneurysms in bilateral MCS. So normally how do we plan is like what are the important dimensions when we look at an aneurysm? The main important dimension is the neck dimension and also dome to neck ratio. Widest diameter by neck, that is one more, and aspect ratio is there. So how do we define wide necked aneurysms? Wide necked aneurysms are aneurysms with a neck which is more than 4 mm, or if the dome to neck ratio is less than 2. So there is a problem of any device staying in it or prolapsing into the parent artery when it is a wide neck aneurysm. Just a historical review on how management of aneurysm has progressed. Previously, there was only clipping that was done by neurosurgeons, and now from 1991 there was coiling, and then for wide neck aneurysms, they have found many more options like balloon assisted coiling and also stent assisted coiling. Stent assisted coiling, usually Neuroform Atlas, yeah, Solitaire, all these are laser cut open cell stents are preferred. And these flow diverters were first approved in 2011. So flow diverters are very flexible. These are braided stents, and they cause flow diversion, as we have already discussed, with complications. But and there are different flow diverter devices that are available in the market. Popular ones being Pipeline, Silk, Fred, Surpass, Derivo of different companies, and and these are the latest intrasaccular devices that are available. Web is woven endovascular bridging device, and this is the contour that we have used in our patient. So main advantage with the intrasaccular bridging flow disrupting devices are basically that we don't require dual antiplatelets and all this. There are other intrasaccular devices also. So we had a check angio from Jan 2023, but due to a technical problem, this video is not playing. But there is no residual. Both the FD and contour are patent with parent. There is no aneurysm seen now, with parent branches opacifying normally. And coming to the ADPKD and intracranial aneurysms. So as we have told, this is a case of ADPKD. So intracranial aneurysms are seen at least in 9 to 12% cases of ADPKD, and normal mean age of rupture in patients with aneurysms are 50 years, wherein ADPKD they have multiple aneurysms and mean age is also 10 years less, which is 40 years. And intracranial rupture is the most severe complication with 6% mortality rate. So screening of patients with ADPKD, especially when they have a family history of aneurysms, is very important. Thank you.
So, thank you, Nikila. So this was a unique case, 41 years old lady. She had a setting for autosomal dominant polycystic kidney disease. So there were three vessels which were diseased. One had a dissection of the carotid on the right side, long segment, which was treated by putting a self-expanding carotid stent. On the same side, the middle cerebral artery bifurcation, there was aneurysm. On the left side, there was another aneurysm. So one side it was treated with the flow diverter. On the second side, it was treated with the endosaccular device. Since the metal to artery ratio was the major concern, in the second side we tried to use the contour endosaccular device, hoping that the chances of thromboembolic complications or long-term patency effect would not be there. So that was the whole idea of treating with the different devices, even though aneurysm looked more or less similar, mirror image. So with this, if there are any questions, then we would like to address them.
Just to one clarification, what I understood is Nikhila told these devices are bigger as compared to what means these devices are bigger. This contour device is bigger. That's what you mentioned probably.
Bigger means the size of the aneurysm. We need to have a good wall apposition. So they will adapt to the aneurysm size. And there are two different sizes available, and based on the proper sizing, we select the size.
This you're saying contour. It is very important to cover the neck completely.
Yeah, got it. So in that context, is there a possibility that the chance of rupture will be more with this device as compared to?
No, because sizing is important here. We'll select the appropriate size based on the size of the aneurysm. So size selection is important. That's what important.
Sir, is there any literature which suggests that there is?
No, this doesn't have a much radial force on the arterial wall. It will not bulge it. It will adapt to the size of the aneurysm.
Thank you, sir.
Malposition is reported. Malposition is reported if your catheter position is not appropriate, longitudinally oriented. So that's why I think it's technically, yes, it's challenging, but once you learn it, I think you can do it. It's a very safe procedure. And the biggest advantage is you don't have to prime the patient with dual antiplatelet. That's the biggest advantage, especially in the ruptured aneurysm.
Neck diameter very important.
Yeah, that's
We
important.
have to cover the neck. If we cover the neck.
Yeah. Any other question related to flow diverter or carotid stent? Flow diverter means you are putting the device inside the artery, main artery, which is harboring the aneurysm. So if it is anything inside the artery, naturally it will be having more thromboembolic phenomena like instant thrombosis, acute complication. To avoid that, we generally prime the patient with dual antiplatelet agents at least 5 days in advance. But suppose it's a ruptured aneurysm, then we do it on the table after the patient is induced. That is also a thing. Then we can put the patient on dual antiplatelet agent the same evening after 12 hours. And subsequently, we do it in the dual doses twice. So morning and evening, that's it. Oh no, these are very expensive devices. Many patients are not able to afford that. But then cost effective for an aneurysm means what? You are putting a coil. If it is suitable for coiling, just simply put the coils. But the rate of coil compaction is quite significant. It's not so simple. Maybe, yeah. Any aneurysm which is more than say 4 millimeter will have a chances of recurrence. So in order to avoid that, these devices have come up now as another treatment algorithm. 7 to 8 lakhs is the cost per device. Yeah.
So in one of the mechanisms, how they work, it was written that in addition to reepithelialization, it also works by thrombotic formation. But if you are giving DAPT, isn't it counteracting that mechanism?
Good question, I think. So you're talking in terms of flow diverters?
Yeah, in
Right.
flow dive.
So flow diverter is inside the main lumen of the artery. So in order to keep the patency, we put the patient on dual antiplatelet. But what the flow diverters does, it diverts the flow from the aneurysm towards the main artery. It's diverting the flow. But whatever flow is there inside the aneurysm, it stays back. So inducing the stasis. So the stasis induces the endothelialization. Even the foreign body which is scaffolding the neck of the aneurysm also promotes endothelialization. So it will not cause lysis inside, right? But it will maintain the flow inside the lumen of the artery. So this is how it works. But yes, if there is not enough stasis, means there is sufficient flow going inside the aneurysm, then the anxiolytic effect can happen, and the acute rupture or delayed rupture of the aneurysm is a known complication with flow diverters. Okay. So thank you for your kind attention.
Good afternoon, respected faculties, my dear colleagues and students. Today I am presenting a case of the topic is itself very interesting, case of near death. So whenever I see this case or whenever I remind of this patient, I always remind of the movie The Final Destination. So how is related to that we will see in the next next few minutes. So Dr. Arunath from Department of Neurosurgery will present the history. I'm Dr. Rajesh Mina from the Department of Neurosurgery, Associate Professor. Over to Dr. Arun.
Good afternoon, everyone. So this was a 25-year-old male. Patient had a road traffic accident. A two-wheeler skid at 7 p.m. on 14th December. Patient had fresh wooden stick piece that had pierced his left eye, and he was irritable and blind from both eyes. On neurological examination, he was E4, V5, M6, GCS wise. Green colored wooden stick was protruding from the left eye with complete ophthalmoplegia in the left eye. So perception of light was negative in both eyes, and pupils were dilated and fixed in both sides. The rest of the neurological examination was normal and there were no signs of meningeal irritation. The radiology part will be discussed by Dr. Nikhila. Over to Dr. Nikhila.
This is a scout image of the CT. Here we are seeing that there is a foreign body. Play video. This is the NCCT brain. Here we are seeing this was a wooden object, hypodense object that is piercing through the left eye, and it is coming up to the prepontine cistern. Going to the next slide. And on the parenchymal window, here we are seeing that there is hypodensity within the right PCA territory. Right PCA territory, there is an acute infarct. Even pons is hypodense. This is a CT angiogram. CT angiogram that was done in the trauma center. Here we are seeing that right ICA right ICA is completely cut off, like only we are. So here we are seeing that the object is coming from the left side and it is piercing the right cavernous sinus and extending up to the prepontine cistern. So in the CT angio, we can see that this is actually a wrong rotation, the left side and right side. Right ICA is not seen, matlab it tapering off is seen in the proximal right cervical ICA. This is tapered. So we have done a DSA for this patient. Right CCA run showing just stasis in the proximal cervical ICA. Left ICA is showing good cross flow, and we are seeing that MCA and ACA are completely reperfused. On this vertebral artery run, we are seeing that right PCA territory is not perfused. I mean, there is stasis in the right P2, P3 PCA, and we are not seeing flow in any distal branches. And that PCA region is also not perfused. And we have already noted that in CT that there is an infarct in the right PCA. Actually, on the oblique image, we were able to appreciate that there was at the P1, P2 junction, there is a filling defect. So that wooden object that we are seeing is piercing the cavernous sinus, and it is coming into the prepontine cistern, and it is impinging on the P1, P2 junction. I can. Cavernous sinus, and here prepontine almost coming up to the ambient cistern, and it is impinging on the P1, P2 and causing thrombus formation over there in right P1, P2. So our findings were that right ICA was completely knocked off because of the cavernous sinus, the object entering into the cavernous sinus, and right P1, P2 also there is thrombus formation because of the wooden object impinging on P1, P2. and left ICA was okay, but left ophthalmic artery was not seen because that was penetrating through and through the eye, which was being reperfused from the left ECA.
Thank you. So the unanimous decision for this patient who has a near-death experience. First, the twig which was preventing the whole stick to go inside the brain and injuring the major vessels. So that twig has saved the patient. Second thing, it has a very good cross flow. So patient, despite the ICA on one side gone, has a very good cross flow. So he was survived that uh, injury also. So the unanimous decision for this patient was to operate the patient, and the operation should be done as soon as possible because the longer the foreign body would be in the wound, there are chances of infection. So with consultations from neuroradiology department and ophthalmology department, we decided to go for surgery in this patient. However, there was a dilemma in the surgical approach. Some consultant from our department said ki you have to do transcranial route, remove, open the dura, see the tract, see where the foreign body was, and if it is impinging any vessel or not, and take control and then remove it slowly. So that was the one option. Under full control, if any bleeding occurs, we can control it by doing a craniotomy. The second option was going through a transorbital route and pull out the stick with some risk involved in it. But since the patient vision was already gone, he was bilateral PL negative. Right ICA was thrombosed. There was right P2, P3 infarct, and cavernous sinus was also injured. So and the track was dirty. So if you go through an open procedure, which is a very long procedure, very lengthy procedure, there are chances of increased post-operative morbidity and mortality in a patient who is already morbid because of so many vascular insult. So we decided to go through the transorbital route and pull out the stick with some risks. So this is the next I will show some in the interop video. These were the operative findings. So patient was placed in a 3-pin neutral position, and we made an adequate expose for decompressive craniotomy. In case after going the transorbital roof, there are chances of bleeding, or if we cannot control the bleeding, then we have to do decompressive craniotomy and do whatever we can. So wooden foreign body was gradually removed under general traction. So it was penetrating through the medial part of the orbit, fracturing the lamina papricea and extending into the cavernous sinus. The tract created by the foreign body was inspected through microscope and followed by endoscope, and all the foreign spicules of the wood were removed. Bleeding was encountered from the cavernous sinus, which was controlled with gel foam, and it was washed thoroughly. Tract was reinforced with the glue, fat, and surgicin. So this is the video of that. So this is the wooden stick. The patient was placed in supine position. So first we'll going through the transorbital route. We try to remove the stick by a gentle traction, but it was too difficult. So one of my assistant also tried, but it did not come out. So we use a sponge to generally gentle manipulate it. So after applying some force, that that branch part has somewhat come out. So using that as a handle, we generally we gradually rotate it and remove that foreign body. So the next part we use our microscope, and we gently removed all the all the wooden spicules that were present in the wound. because the main problem with the wooden is that it is a porous material and it is organic in nature. So if it is left behind or the spicules are left behind, there are chances of infection, very high chances of infection. So it is by using the retractors, we are trying to remove the pieces of uh, stem in bits and pieces. So we have ophthalmologist colleagues from were also present intraoperatively. They also assessed the orbital component, and the globe was intact and it was turgid. So no intervention was required from their side, and it does not rupture the globe. Only that because of optic chiasmatic injury, patient was PL negative. So the by slowly removing the bits and pieces, we are going deep inside. But after a certain point, we are unable to remove them completely. So after this point, we use endoscope to remove further bits and fragments of the tissue. This is, you can see the orbital wall, that roof of the orbital wall, it has been destroyed. So this is the endoscopic view, and you can see the pieces of woods everywhere. After achieving hemostasis, we packed the cavity, and there was no CSF was coming through from this wound, but we packed the cavity with a fat Sagicel, followed by tissel glue. So this is the post-op, this is that intra-op, and this is the wood stick that has come out, and with bits and pieces of wood, whatever we can remove, and it is about 15 centimeter long. Thank you. The post-op course will be by Dr. Arun Nath.
Thank you. Patient had a uneventful post-op day 1. Patient was extubated on the next day without any fresh neurological deficits, and the patient was started on broad spectrum antibiotics. This is the post-op CT showing there was no hematoma in the cavity, and there was evolving right PCA tertiary infarct. And also the MCA branches also showing area of infarct. Patient had a fever spike on post-op 10 associated with a dip in GCS from M6 to M5. He was intubated. The repeat CT was done. It was same as the immediate pre-op CT, and fever workup along with CSF workup was sent. The CSF KOH mount showed septate hyphae and elevated CSF galactomannan levels, which was suggestive of fungal etiology. The confirmatory tests for fungal infection like cultures, Indian stain, and cryptococcal latex agglutination tests of CSF were negative. And in view of suspected aspergillosis, the patient was started on injection voriconazole after ID infectious diseases consultation. Injection voriconazole 400 milligram BD for 2 days followed by 200 milligram BD, and patient self-extubated on day 12, and the fever had also completely subsided by day 12, and the GCS improved to M6. Patient remained febrile and uneventful during the rest of his stay in the hospital. The total dose monitoring for voriconazole was done, and the dose was maintained at around 3, which was in the normal range during his hospital stay. And the patient was discharged on post-op day 21 and E4 full GCS state, febrile with deficit same as the pre-op state, with complete ophthalmic PG in the left eye and PL perception of light negative on both eyes, and the injection of voriconazole was converted to oral voriconazole, tab voriconazole 250 milligram BD. Follow-up will be uh, discussed by Dr. Rajesh. Over to Dr. Rajesh.
So patient was discharged home. So he came after 15 days after discharge with an MRI. So the patient was on oral voriconazole and he was somewhat irritable. Otherwise, he was fine. And CCT head shows only that that infarcted area there is hyperdensities and nothing much significant. So also MR angio, which shows the same radiological findings as before. So our case survived. He was sent home. So little bit about the literature that non-missile, non-metallic, like wooden transorbital penetrating injuries are rarely reported in the literature. Most of the patients belongs to the pediatric age group, and less than 20 cases have been reported. And most common mode of injury is fall, and it is associated with high morbidity and mortality. Vascular complications are seen in about 50% of the cases, like SAH, arterial dissection. Infection rate is also high, around 64 to 70%, and mortality is around 40 to 57%. So diagnosis depend upon the complete physical examination and full neurological and ophthalmological examination. We have to do all the gamuts of investigation to see what are the bony injuries, what are the vascular injuries, any orbital, and what are the cranial injuries. And the interesting part about the wood have a air-filled porous microstructures, and that can mimic a pneumocephalus. Sometimes a small specks of wood when you see on a CT may be missed out. Uh, because it may mimic pneumocephalus. So we have to do all gamuts of investigations to rule out all other injuries. So management is a team approach. It's involved a team approach, multidisciplinary approach involving multiple specialty like facial-maxillary surgeon, ophthalmologist, neuroradiologist, and because of porous consistency on organic nature, that would act as a medium for microbial proliferation. So there are high chances of infection. And whatever the cases reported in the literature, surgery is a major strategy for the removal. And from neurosurgical point of view, decompression of the neurovascular structure and the removal of foreign body under direct visualization should be done. So surgical approaches are divided. Some do transorbital approach or transcranial approach, whatever feasible. for the patient. This is a review of the literature. Around less than 10 cases have been reported involving chopsticks, bamboo fragments, pencils, and most of the literature, they have reported a good recovery in their patient, and none of them have reported the fungal etiology in their patients. So before the presentation, when I was going to make this presentation for the case of the death, I telephoned the patient. What about the status? I want to take the video to show that the patient is walking, talking, or night. But the relative said he expired 2 to 3 days back. He expired 2 to 3 days back because he was maybe seizures. He became unconscious while taking to the hospital. He was not timely intervened. That was he died. So take-home message is they are very rare, associated with high morbidity and mortality, and removal of foreign body outside the operating room should be discouraged because they may be acting as a tampon to the bleeding point. So if you try to remove it outside control manner, it may lead to disaster. And timely intervention, appropriate pre-operative assessment is very essential. It involves a multidisciplinary team approach. Thank you. So I will call Dr. Gagandeep from the Department of Microbiology to say a few words about the fungal infection and what are the better ways to diagnose it.
So good afternoon. Even for us, this was actually a very surprise finding. Normally in CSF, what we are looking at for are usually cryptococci. We don't think of anything else except these. And for whenever we get a CSF sample, the investigations that we do in routine are the India ink so that we can demonstrate the capsule, culture it, and also we do a gram stain. So this was actually first picked up on a gram stain. We never suspected it. So our resident saw septate hyphae on a gram stain. So we went back, did a AOH mount or a wet mount and saw that even the wet mount contained a septate hyphae. And so that is how we made the diagnosis. And for fungal infections, if we can demonstrate septate hyphae or fungal elements from any sterile site, that is supposed to be taken as a proven case of fungal infection. This, as is a common scenario, fungi are difficult to retrieve on culture. So here also we did not retrieve this on culture, and also we had done therapeutic drug monitoring in this patient. Once at least we had done, and probably I discussed with Dr. Rajesh also, probably because voriconazole is not an easy drug to even buy from the market, and so probably he shifted over to a locally made voriconazole, and the therapeutic levels were not being maintained. I'm just hypothesizing of why the patient deteriorated. I'm not sure. And so in these, at least in such cases, a monthly TDM for voriconazole should be done just to assess whether the patient is maintaining the recommended level. Thank you so much.
Thank you, sir. Sir.
But fungal infection in the presence of a foreign body is not surprising at all.
Yeah, sir, but the literature review.
I think as a routine, if there's a patient with foreign body, we will give antibiotic and fungal prophylaxis. Because these are organic, as you said yourself, wood is organic. So fungal infection, I don't think so is surprising in this patient.
So, sir, we done an ID consult and they started, the prophylactically started on fluconazole. Fluconazole they have started.
Yeah, that's okay. That's okay. So the first line of drug obviously is fluconazole, but I think I don't know whether doing routinely transplant. So we are used to using voriconazole very frequently now.
So we should.
We have given up actually using fluconazole routinely for prophylaxis if the patient we think is having fever and fungal infection. So now routinely we are not using fluconazole anymore actually.
So what is your point? So we should start.
What I'm saying is that in the presence of a foreign body, fungal infection is very common.
So we should start prophylactic
Yes,
fluconazole.
yes.
Yeah.
One should always. Voriconazole. Yeah, more active agent. Yeah, okay.
Yeah,
She's here.
yeah.
So we generally consult ma'am actually for such cases, and we generally switch over the patients very quickly to voriconazole actually now. Fluconazole, actually, there is a lot of resistance now, I think. It doesn't work at all, yes. Yeah, previously, like in renal transplant, we were giving fluconazole to all our patients as a prophylaxis. But now we have stopped that because it's not serving any purpose. And if we suspect a fungal infection, or as I said, if you see some hyphae or some septate, then we immediately put these patients on voriconazole. We don't wait for the cultures to grow or anything.
The next question is how long do you give that voriconazole? It's a
You can answer.
yeah. How long do you want to give a voriconazole for such patient if we suspected that ventriculitis or meningitis for this patient? Because
Actually,
the only drug is that fungal infection. What is the organism? What is the culture? We are no clues.
actually, it doesn't depends on the culture or patient improvement. Patient to patient, it varies actually.
So how long do you suspect for 2 months or 3 months or one? What is the course? If the patient is improving, we can stop it or we should continue.
Yeah, I can try to answer this question. In the context in which we see it is, of course, far less pressing and urgent. We have subcutaneous infections where we treat with itraconazole and sometimes voriconazole, and it's very tricky deciding when to stop. So what we are doing most of the time is complete clinical improvement plus 3 months.
Plus 3 months. So I doubt. I'm not sure, sir. He was operated on almost 1 month after surgery. Maybe that ventriculitis has flare up or the meningitis have flare up. Second option, he may develop a seizure because anyway the cortical hyperintensities were there. We never know, but autopsy or that would be that. No, sir. At the time of this, at the time of he came to OPD, so I advise contrast enhanced MRI. So he did an MRI and he presented to the OPD. After that, he has to come after 1 month, but between that he died. Sir, he was brought to some hospital, but not at AIIMS.